Hello, everyone. I'm Dr. Ian Cohen. Thank you for joining me for today's presentation. And we will give people a few more minutes in order to allow people to join. Perhaps they're finishing up with their last morning patient and need a couple extra minutes. So we'll just allow that before we get going. I know we had a fair number of people who signed up to join us, and so I'm hoping that they're able to get connected and be able to participate. So we'll see, hopefully, if they can log in shortly. And for those of you who joined right at 12 noon, I certainly appreciate your promptness. I can see a few people joining the group now, so that's slowly adding in, so that's great. I think we'll just give one more minute and then we'll start. Okay. Why don't we get going, and hopefully those of us or those who join us in the next short while can catch up, and we'll welcome them as they join. So my name is Dr. Ian Cohen. I am a physician at Toronto Memory Program, which is located in Toronto in the area of York Mills and Leslie. And my background is in family medicine, but I've been practicing in this area of aging and medicine now for the last 15 years. And Toronto Memory Program, where I currently practice, is the original practice of Dr. Sharon Cohen, who you may know of, who is a behavioral and cognitive neurologist, who leads both our memory clinic and our research program. So we are a clinical trial site for most of the large global studies looking at new treatments for Alzheimer's disease. And our memory clinic sees people that are referred to an OHIP covered clinic for assessment of their cognition. So today we're going to talk about early Alzheimer's disease, what that looks like in 2024. And The objective is to improve the understanding of what exactly is early Alzheimer's disease with respect to the conceptual framework of how we make this diagnosis, the importance of early detection and why that's actually becoming even more important at the moment, the assessment process that you would take in your practice, the role of biomarker testing, which is something that you would not necessarily have access to, but is definitely coming in the very near future. Treatment options, those which are lifestyle based and those that are pharmacological and what's currently approved and what we hope will be approved shortly, and then the role of clinical trials. So this has been a fairly long road. Back in 1906, a German neurologist by the name of Dr. Alois Alzheimer's described the first case in actually a middle-aged patient, Auguste D., who developed symptoms in her 40s and died at the age of 55. So someone we would now call early onset Alzheimer's or young onset Alzheimer's disease. And he described the symptoms, the cluster of symptoms that she presented with. And then after she passed of this, at that time considered a rare disease, he did what was done at the time, which was to do an autopsy and looked at the brain of this patient and identified through tissue samples of what you're seeing here, the presence of what we describe as the hallmark features of the disease, amyloid protein plaques on the left, and neurofibrillary tangles based on damage to the tau protein. And these are still considered the two hallmark features of this disease. And initially there was interest, and then there wasn't much discussion about Alzheimer's disease for decades until sort of the 60s and the 70s, and then started to become something which became of interest as the population aged and we had more people developing symptoms because they lived longer. But Dr. Alzheimer's had it right at the beginning. It was a clinical syndrome, but it was confirmed by autopsy by a pathological diagnosis. We have a better understanding now actually of the entirety of Alzheimer's disease. So this graph explains this. On the left-hand axis is cognitive decline, and across the bottom is time in years. So we now understand Alzheimer's disease as a 30-year-long disease. Across the top of this graph, you see normal aging, and you see a couple different neon lines here that show someone who really isn't changing over the course of their lifetime, and some who may show some slight decline. So this phrase in this graph, which says everyone experiences slight cognitive changes during aging, isn't actually accurate, in that many people that we know who are in their 80s are sharp as a tack and haven't had any changes. But as we age, especially later aging, there may be some symptoms, but not that would be considered normal aging. Alzheimer's disease starts silently in the brain in the preclinical state, and this is about half the course of the disease. So the first 15 years of the disease is the stage where pathology, amyloid plaque, is accumulating. And eventually, towards the end of this period, tau tangles are starting to form. And we call this the silent phase. So the brain changes without measurable symptoms, maybe the presenting situation, someone who's worried about their risk because they have a family history, or an individual may notice some changes, but if we do cognitive testing, they score normal on our tests. We used to call this the worried well. Now we call this subjective cognitive decline. And this is the stage where the patient knows, they know themselves best, they know there's a change, but the doctor doesn't. And unfortunately, we could say this even based on our underdiagnosis of this disease, even in the MCI stage where the patient knows, they may come to you and they may say, I notice a difference, I notice a change, but it's not addressed. So the patient knows it's important to listen to them at all stages. The second half of the illness, approximately the last 15 years, are the symptomatic stages. The first being mild cognitive impairment, which lasts, let's say, on average 3 to 5 years. Now there are cognitive changes that are of concern either to the individual or their family. There's actually objective evidence of impairment in at least one domain, but they're still independent in what we call their instrumental activities of daily living. As the disease progresses and the progression steepens over time, they go into the dementia stage of the disease, which is broken down into mild, moderate, moderately severe, and severe. And in the dementia stage, basically, the change is now they have lost some degree of ability to perform instrumental activities of daily living. That's the distinction for dementia. And if you follow this red line out to the end of the graph, the important point to note here is this is a fatal disease. People may die at the end of other conditions. They aspirate, they get pneumonia, but Alzheimer's is a fatal disease. So what exactly is early Alzheimer's disease? It refers to two stages of the Alzheimer's continuum. The first would be mild cognitive impairment due to Alzheimer's, and the second would be mild dementia due to Alzheimer's. So this is early Alzheimer's disease. And in order to make this diagnosis, it requires two components: knowledge of a clinical syndrome, so you're describing mild cognitive impairment, you're describing mild dementia, as well as a biological confirmation of Alzheimer's. So now determining before someone dies that they have the plaques or the tangles, and that is the etiology. This should not be confused with early onset Alzheimer's disease, which is a term used when symptoms develop before the age of 65. So what exactly is mild cognitive impairment? Again, it's a clinical syndrome. It's characterized by a cognitive complaint either by the patient, the informant, or a knowledgeable clinician seeing the patient. There is objective evidence of cognitive impairment on testing in one or more domains. So what are those domains? Memory, executive function, attention, language, or visual skills. And depending on the origin or the etiology of their cognitive impairment, some of these may be more pronounced or predominant early on versus later. And the third is preservation of independence in daily function. Although individuals may be less efficient or less confident, it may take them longer, or they may be reticent to do things when performing these IADLs compared to their previous normal. So what's the difference? What is dementia? As I mentioned before, it's also a clinical syndrome, but it's characterized by cognitive decline sufficient to impair or affect daily function, or IADLs. So they are no longer able to do that aspect of their daily function. There is also objective evidence of cognitive impairment on testing in at least two or more domains. And this is a clinical diagnosis. It's made by taking history, cognitive testing, and doing a functional assessment. MCI and dementia are not a normal part of aging. So being able to say, well, what do you expect? You're older. This is what, we see when people get older. That's not accurate. When people get older, their cognition is preserved. So if you see this, this is not normal. Why is this becoming, sorry. Why is early Alzheimer's disease important, and especially since the field is changing and evolving? For many reasons. So patient and families, they deserve a clear explanation for their cognitive concerns. Working in a sort of a tertiary care, we have many patients who come to us, unfortunately, who feel that their concern about this hasn't been addressed. And the example that I give is somebody might go to their physician and say, well, I think my blood pressure is elevated, and the doctor looks at them and goes, no, I think your blood pressure is okay, without actually taking their blood pressure. And I think taking the next step when you see patients with these concerns is very important, whether it's cognitive assessment or taking a history is really necessary so that they can get answers to their concerns. It's also important because there are some reversible causes of mild cognitive impairment or mild dementia that we'll talk about. And early in the disease, there is still viable, unaffected brain left to protect. So making, whether it's lifestyle changes or treatment decisions that can preserve cognitive reserve early on in the disease, will have a greater impact than later, where those changes those interventions may have no effect. It also gives the patient the opportunity to implement brain healthy lifestyle strategies, which we'll touch on. and implement strategies to keep them in the workforce. I've had many patients who were let go from their work because their performance had declined, and it turned out, well, they were in the mild cognitive impairment stage of the disease, and identifying that might have allowed them to be placed on a modified work plan in order to keep them in the workforce. It also allows us to put in place safeguards to protect patients from harm and allow for care planning. So perhaps to do with banking or protecting them from authorizing certain financial transactions. It also gives us the opportunity to educate partners and their families on how they can help and where to find help, and to help them understand exactly what their partner is going through. And what's changed recently, these have all been true in the past, but what's changed recently is that new disease modifying therapies are indicated and effective for early Alzheimer's disease and may be approved shortly in Canada. So patient comes to you, what do they say? How do they present? What are the symptoms suggestive of early Alzheimer's? What are you going to look for? So this might be someone who's as young as 55. We tend to think of, well, in their 70s or 80s, it's on our registry or on our mind that our differential is Alzheimer's, but don't disregard the complaint of a 55-year-old. We see lots of people here in their 50s who have Alzheimer's disease. So it could be 55, it could be 63, 69, 78-year-old male or female. And the clue is that it's an insidious onset and it is slowly worsening. They may comment, I have trouble remembering recent events or characters or plot in a book, movies I've just watched. My family says I'm repeating myself, so here's memory domain impairment. I can't find the word I want to say, so language impairment. I have trouble following a conversation with two people, and everyone needs to be quiet in the car now for me to focus. I lose track of what I'm doing if I'm distracted. That's the classic example of someone's left something on the burner, but they can be more subtle. So this is attention domain. It takes me longer to complete tasks, or it's harder to plan the family dinner or an event. So executive complaints. I'm relying on my GPS now, otherwise I might lose my way. So navigation or wayfinding domain. And very commonly with early symptoms, I'm frustrated, I'm more irritable, I'm anxious because I can't do or perform the way I want to, or I'm feeling sad that I'm losing who I am, or that I'm changing. Those are often accompanying early stages of the disease. There are some alternate presentations that can be suggestive of Alzheimer's, in which case the patient may say, I have no problems, but it's the family who's there describing that there's a number of changes that they recognize, and they're stating that the patient is just in denial, and that they actually have a number of impairments in managing their daily activities. And here's the situation where the family recognizes the problem, but the patient has lost insight. That is the I have no problems. They are unable to identify their own decline. So now you have a sense of, well, what cognitive domains are affected. Now you want to get that functional assessment. So a focused history is the ideal way to do this with the patient and potentially their family member or partner, and you're looking for changes in their IADLs, or instrumental activities of daily living. So are they having difficulty managing their work or taking their medication? Looking after planning of meals. Maybe they can only make simple meals, more complicated ones have been dropped. Can they do their regular housework? How are they managing with their banking? It may just be they can't remember their PIN, but they can still do their banking, or some degree of difficulty. They're missing payments of checks. Can they keep up with their appointments, or complete complex tasks? What about using tools or computers or appliances? We talked about navigating. Are they getting lost? Are they having to call for directions, or showing up much later than they would normally have expected to be home? These are the domains that you want to inquire upon to determine the impact of this. So if it turns out that they have no impact, no impairment in their IADLs, or they are independent, that's consistent with mild cognitive impairment. But if they say, I'm using strategies, so now I'm writing notes, I have lists, I've got alarms and prompts going, I'm using a GPS, I put my medicine in a dosette to try and keep track, and they are still managing to be independent because these strategies are supporting them, then this is still consistent with MCI. But if they describe that my spouse has now taken over the banking, or I can't keep track of my medicines and my partner's now making sure I take them, they are no longer independent in their IADLs and they have moved to the dementia stage of the disease. If they say, I stopped working because of my cognitive changes, but since I've stopped working, I'm independent in my IADLs around the house and all of those other things, this is still consistent with dementia. Interviewing the informant is important. Early on in the disease, patients may well have an adequate history to describe these, but as they progress in the disease, they may not recall the extent of their impairment. So informant-based either interview or assessment tools like an FAQ are useful at this stage. What about neuropsychiatric symptoms? So they're common in Alzheimer's disease, as I mentioned before. They tend to fluctuate over the disease course, with more serious ones showing up later. So in early AD, the common neuropsychiatric symptoms include anxiety, depression, and sometimes that's the presenting symptom. And you treat their anxiety and depression, and the concern that they had that their memory was not as good as it used to be doesn't improve. Frustration, irritability, anger, social withdrawal or apathy are also present because now they're reticent. They're a little uncomfortable in parties where they may have to communicate with more than one person at a time, or what if they forget a name, or they can't sort of keep up with the conversation. These are common in early Alzheimer's disease. As the disease progresses to the moderate or severe dementia stage of Alzheimer's, now you start to see more agitation, perhaps associated with sundowning, some memory-based delusions like, oh, someone is still alive even though they've passed away. They're worried now that people are stealing from them because they can't remember where they placed things, so paranoid delusions. They may start wandering or have a reversal of their sleep-wake cycle. Again, these are later symptoms. What's uncommon in Alzheimer's disease would be visual hallucinations, which would be more suggestive of a non-Alzheimer's disease etiology, especially early on. Okay, so now you've got their symptoms, you've assessed their functional impairment, you understand whether they have any NPS or neuropsychiatric symptoms. So now we want to do that objective test. We want to put that blood pressure cuff on them to see if their blood pressure is elevated. Well, now we need an objective test to see if there is impairment present. The selection of the test is really important. And part of the decision making that goes on is based on what is the suspected level of impairment. So the test you choose for MCI will not necessarily be the test you choose for dementia. The level of education is important, as well as their occupational attainment. Again, because if they're developing, if you choose a test that has a threshold for abnormality here or here, yet they're still declining. If you choose a test that's here, it's going to take you longer to identify that objective impairment as opposed to the test that's more appropriate early on in the disease. So these are important considerations. Objective testing for MCI, there are a number. The one I'm going to focus on is the Montreal Cognitive Assessment. It is a test specifically for MCI. Why? Because it's sensitive for differentiating people who are very early in MCI from normal cognition. A normal score on the MCI would be considered 26 over 30 or above. But if you have a patient where you have 26 over 30, but when would it not be considered normal? Well, if their memory score is 1 out of 5, that's not a normal test, even though the overall score may be normal. Analyses, statistical analysis have found that roughly an MCI, a MoCA score of 17 or above is a good cutoff for the other end of the scale where you're distinguishing between MCI and dementia stage. And this cutoff has a high sensitivity of around 92.3% to capture MCI cases. If you alternatively were to use an MMSE for diagnosis of MCI, the sensitivity that I've listed here is anywhere as low as 45 to 60%, but there are other studies that show the sensitivity can be as low as 17%. So you will miss the MCI by using the MMSE. For the MoCA now, in order to do the test appropriately, to make sure you're getting the most accurate result, there is a certification process through the MoCA website that you can sign up for to make sure that you're doing the test appropriately. Now, the MoCA group is starting to roll out other versions of their MoCA. There's a MoCA Duo, which is actually a digital version of the MoCA. There is a free version for healthcare professionals and for academics who are using it for clinical trials, where no training is required because they have built in some of the automated features that would be part of the training. So this is just an example of some of the tools or the cognitive testing sensitive for MCI. If we want to test people for dementia, the MMSE is the more appropriate test. And you may start out doing a MoCA and find that the person cannot complete the test. After a few of the domains, they're really struggling. Obviously, they're going to do poorly on this now. You would move into doing an MMSE instead. So an MMSE score of 26 or above is considered normal. But again, what is the score on the memory test, the recall test? If their score is 0 out of 3, even though they might have a 27 out of 30, let's say, or 26 out of 30, you've detected or you've picked up a very selective domain of impairment. And then there are other scales here, but just as a rough guide, I've used these brackets of 20 to 25 out of 30 would be the range that we might expect to see in mild dementia. 10 to 19 would be in the moderate dementia stage, and less than 9 would be in the severe dementia. There are some other scales that sort of, modify these, but this is a rough guideline for this, how you would use this test for staging. So now you've done your full assessment, you've got your symptoms, you've got your function, you've got your neuropsychiatric assessment, and you've got your objective testing. That is all you need to make a syndromic diagnosis. So either this is a person who has no cognitive complaint and they have normal cognitive testing. So this is normal cognition. We would say to the patient, you have normal cognition. However, someone who has a complaint, but their testing is normal, we would label that as subjective cognitive decline, which is a very important stage to identify because this is perhaps the earliest symptomatic stage of Alzheimer's disease. There are many other reasons, but this is something we need to pay attention to. Or you may determine, no, this is mild cognitive impairment based on what we've talked about before. And then what you're starting to look at is, okay, what is the presentation here that might lead me one way or another in my thought process about what are the potential etiologies? So is this an amnestic presentation, so memory, or is this a non-amnestic? Maybe this is language that the problem is and not memory. And is this just one domain? Or are we seeing multiple domains? And I'll show you a slide in a second that sort of breaks this down into what we might interpret these when we're thinking about what is the etiology or the next step. Or is it dementia, mild, moderate, or severe stage? So when we're thinking, let's say, about mild cognitive impairment, I believe this is a chart that's used from the DSM-5 that tries to distinguish between how you would look at this. So on the left-hand side, you see amnestic MCI, so memory is mainly affected. You do your cognitive testing. It's a single domain, so memory is the most common. Short-term memory impairment is the most common presentation for Alzheimer's disease. So on the bottom left, you can see, okay, that's my concern. If it's memory and other domains, it may well be that it's still Alzheimer's disease, but now other domains are affected because you're getting into the later stages of MCI. So you're still thinking about Alzheimer's, but if they kind of present it all together, maybe you're thinking, could this be a vascular etiology? On the other hand, on the right-hand side, if this is a non-amnestic presentation, this is, let's say, a language presentation. They cannot identify words. They don't recognize what words are. They're not speaking grammatically anymore. They can't comprehend what people are saying. Any of these features, is it one domain? Is it multi-domain? And now you're starting to think of other causes of dementia, such as a frontotemporal dementia or semantic dementia, or maybe this is Lewy body or a Parkinson's disease dementia. So this is one approach that's used to help us think about where we're heading. But it's as we move forward, as we see what's coming down the road now, this may not be as applicable. So now you have to determine what is the etiological diagnosis. So the key to understand is MCI and dementia, they have multiple etiologies. The etiology will dictate the time course, the prognosis, and the treatment options. So we need to not just call this a syndrome, we need to think about what is the underlying cause of their syndromic diagnosis. Some dementias are reversible, so hypothyroidism, significant B12 deficiency, medication side effects. So we want to be thinking about those as we're going through our investigations. Some dementias are preventable, so if someone's had a head trauma, they have an MTBI, mild traumatic brain injury, and you want to prevent further damage. So there may be actions that you would take knowing this. And be aware that multiple etiologies can coexist. So someone can have Alzheimer's disease and they can have cerebral vascular disease, let's say on their MRI. It doesn't mean they have vascular dementia. It means that what we're trying to explain here is comorbidities are common in Alzheimer's disease because Alzheimer's disease is seen in an aging population where those comorbidities tend to exist. But Alzheimer's disease is the most common cause of dementia worldwide. So this is the kind of dementia differential diagnosis as a nice schematic here. So dementia is the syndromic diagnosis. Those droplets are the etiological. So if we're thinking about how frequent are they, Alzheimer's dementia makes up about 60 to 80% of the dementia cases. And then the others like Lewy body and vascular dementia, maybe 5 to 10%. Frontotemporal dementia, also maybe 5 to 10%. And then the last droplet is the others like Parkinson's or Huntington's. So these are defined etiologies. At the bottom where the puddle is, you run into something called mixed dementias. And mixed dementias are not as common. We get lots of instances where people will say, oh, this is Alzheimer's, but they have vascular change, so this is mixed dementia. Mixed dementia would actually mean they have a diagnosis of Alzheimer's and they have a diagnosis of vascular dementia. They are both present. So how are you going to investigate this? Now you've kind of come down this pathway, this sort of conclusion about where am I? So you're going to look for possible reversible etiologies. So you're going to do blood work to look at the things that we would normally explore, CBC, electrolytes. If it's an acute presentation, maybe they have hyponatremia. You want to look at their glucose, their renal function to see if there's impairments suggestive of enough of a problem that could contribute. How well is their liver functioning? What is their calcium? Do they have hypercalcemia? Specifically, are they hypothyroid? Everything slows down, including your brain, vitamin B12, and then other tests that would be more dictated by history. So for instance, is there a risk that they have HIV? And this is related to that. If sleep apnea is suspected, a sleep study is important. Although sleep apnea may be present, it may not be sufficient to explain the entirety of their presentation, but we know that the resilience of our brain is damaged by anoxic events that happen over many, many times an hour, over many, many diseases, or over many, many nights. So if that's suspected, sleep study is very important. We're learning more and more how hearing is important in Alzheimer's disease, either in the ability to hear the information. So therefore, if you don't hear it well, it's going to be harder to retain it. That's one example. So hearing test is important, especially if hearing loss is suspected. It's not just when the person's having to have the information repeated that they forget that are they actually hearing the information? And then the other test that we want to do is a structural brain image. So the reason for a structural brain image would be to rule out non-Alzheimer's etiologies. So for the most part, I explain to people that when I'm doing an MRI, it's not to show they have Alzheimer's. It is to make sure that we identify something else that could be the explanation or contributing. So CVD, cerebral vascular disease. Do they have infarcts? Especially, do they have what's known as a strategic infarct? So an infarct in an area that could lead to symptoms that present as Alzheimer's. Do they have a chronic subdural hematoma? Or what's the extent of their white matter disease, or what's known as microangiopathy? That is basically the health of your blood vessels. So if you have severe white matter disease, meaning there's a large vascular component of disease in your brain, that could be contributing or sufficient to explain the problem? Do they have normal pressure hydrocephalus, or do they have mass lesions that could present with some specific cognitive impairment? So non-Alzheimer's etiologies. And also, an MRI is actually helpful for identifying findings that are suggestive of Alzheimer's disease, but that aren't conclusive evidence. They are, for instance, hippocampal atrophy in the temporal lobe that's greater than the atrophy in other parts of the brain. And if you look at the images on the right here, there's an arrow, a horizontal arrow in the lower left side that's pointing specifically at the hippocampus. And what you can see is a normal control, normal size of their hippocampus, then an MCI, where now you're starting to see a little bit more space on the left-hand side, and then in mild AD, where that hippocampal atrophy is even greater. So it's a clue to us that damage is occurring in the part of the brain that's, the area of focus of a lot of cognition. Microhemorrhages are selective bleeds that are occurring because of what's known as amyloid-related imaging abnormalities. So amyloid accumulation, not in the form of plaques, but amyloid that accumulates on the edge of blood vessels, makes those blood vessels more vulnerable to bleeds, microbleeds. That's a hallmark feature of Alzheimer's. MRI is preferred over CT. It's just more sensitive for showing the cerebrovascular changes. MRI is able to better visualize this medial temporal lobe, the hippocampus as well. But we're now moving on to some actual ability to detect that amyloid and tau before the person passes away. So how do we do that? Well, there are a number of biomarkers for Alzheimer's disease now that we've identified and can test for while a person is alive. So this is the graph that's similar to the one I showed you before. And on the bottom axis, you can see cognitively normal, MCI, and dementia. And what you see in this cognitively normal period is look at all these lines that are already present, already evident. Same in the MCI. And at the dementia stage, a lot of those have already peaked. So the first line on the left is soluble amyloid. So this would be amyloid that we can detect in the spinal fluid years before symptoms develop. In that preclinical period where pathology is developing, we can now determine that someone has Alzheimer's pathology before they develop symptoms. So spinal fluid is the first to detect that. The next line is amyloid plaque. And the amyloid plaque we can see on PET imaging, which I'll show you a slide of in a moment. That next line is soluble tau, so tau that's present in the CSF. So when we do a lumbar puncture in someone early in the disease, we can look at their amyloid levels and their tau levels. That will tell us a lot about whether this pathology is present or not. And the last line on the right is cognition, which is basically their symptoms. So look at all this pathology that's present for us to identify. Well, now we can identify these fluid biomarkers or on PET imaging. So this is what a PET amyloid scan looks like. We've injected an amyloid tracer that specifically attaches to the amyloid plaque that's present. So we can see this amyloid light up. This is all this red pathology and highlight. So this is what a visual read of an amyloid PET scan would look like. And we can say, okay, your MCI is due to Alzheimer's disease because we have this biomarker, and PET biomarker for amyloid has been validated against autopsy. And so we should be using these biomarkers. They're actually required for the biological confirmation of Alzheimer's disease. We can rule in or rule out Alzheimer's disease now in patients that are living and early on in the disease. And it turns out that without these biomarkers, we thought we were so smart, but in fact, we weren't so smart. A clinical diagnosis, even in expert hands, if I say this MCI, I think this is due to Alzheimer's disease, I'm going to be wrong more than 50% of the time. In MCI, in dementia, I'm still going to be wrong 30% of the time. And we see that all the time here, especially in our clinical trial patients, where we look and we go, yeah, this is dementia. It looks just like Alzheimer's, and their PET scan comes back and it's negative. Okay, so what is it? Well, we're starting to learn that not everything that looks like dementia is due to Alzheimer's, and these biomarkers are making a huge difference. And these biomarkers are coming. So the NIA, National Institute of Aging Alzheimer's Association 2024 revised criteria, the JACC criteria for diagnosing and staging, says that Alzheimer's should be diagnosed as a biological disease. MCI plus a positive core-1 biomarker, which I'll explain in a minute. The terminology there is MCI due to Alzheimer's disease. Dementia plus a positive core-1 biomarker is Alzheimer's disease dementia. Up until now, we've been saying that people have possible Alzheimer's disease or probable Alzheimer's disease based on their clinical presentation. As we move into the era of biomarkers, now we are going to be able to be definitive due to Alzheimer's disease or AD dementia. So what are the core-1 biomarkers? PET amyloid, florbetaben, which is a tracer, an amyloid tracer, has been approved in Canada since 2017. It is available. It is not yet cost covered, and the cost is expensive for a PET scan. For some patients, they will pay for that, but this is available in Canada, and a visual read, there are computer reads as well, but a visual read correlates well with autopsy degree of pathology. The other biomarker, core-1 biomarker, is in the spinal fluid, and there are many that we can assess. We can assess two versions of amyloid beta 40 and 42. 42 is the pathological version that's associated with Alzheimer's disease. We can look at phosphorylated tau. There are a number of different versions. And we can look at the total tau, so the total amount of tau, not just the phosphorylated. And it turns out that when we use ratios of these, we're more accurate than isolated individual measurements. And at this point, we're at the level where these ratios have a greater than 90% correlation to a positive PET scan. We do lumbar punctures here all the time, 2 or 3 times a day. Most of those are due to patients in clinical trials, but more and more of them are clinic patients. And again, spinal fluid assessment is something that we can send this sample off to a lab. Labs in Europe, now there are labs that are starting up in Canada. It's not yet cost covered. It's much less expensive than a PET scan, but it is something that's available and will become more and more common. But plasma biomarkers are the easiest route, so doing a blood test. Right now, they're mainly used in research, but in the very near future, perhaps in a year or so, we expect these will be approved for clinical use. The blood-based biomarkers is p-tau181 or p-tau217, and these actually are markers of Alzheimer's amyloid. So they don't tell us how much tangle is present. They are early markers of amyloid accumulation. There is one company, they do what's called a Precivity's AD2 test, where they actually take a ratio of the amyloid 42 to 40, plus a ratio of the p-tau to non-p-tau, and they come up with a probability score. And over time, these plasma markers are now getting up to the level of approximately 90% diagnostic accuracy. So what's the value of these biomarkers? Well, greater diagnostic certainty, early detection of the disease. And what they do is they give us the opportunity to intervene when symptoms are very mild, in the earliest stage of mild cognitive impairment or mild dementia, or even prior to symptoms. And the challenge is that for patients and family physicians who are seeing cases, sort of waiting until they're in the mild dementia or the moderate dementia to say, well, yes, now I believe you have Alzheimer's, we've missed so many opportunities. We need to identify these people early, because the new disease-modifying treatments that are coming along will require biomarker eligibility because they are anti-amyloid treatments. We need to confirm that they have amyloid pathology present. And also, these biomarkers help us now to run prevention trials. So we have trials going on, 2 trials, one that's still enrolling, the Trail Runner, for people who have no symptoms or mild symptoms. They have a blood-based biomarker test. If it's positive, they enter the prevention study with an anti-amyloid therapy. What are our treatment options? There are lifestyle strategies. These recommendations come from the Global Alzheimer's Platform. Many of you would be familiar with them because they're many of the same recommendations that we use for healthy heart. So a Mediterranean diet, staying active, getting enough exercise. But some that are maybe more specific for Alzheimer's would be sleeping well. That's when we clear a lot of this pathological amyloid, when we consolidate memory. So we're all burning the candle at both ends. We need to make sure that people are getting adequate sleep. Exercising your brain may not be specifically doing a computer game. It may be just maintaining use of your brain in a stimulating manner. But variety is important, consistency is important, and doing it in a social setting is important. In fact, interacting with people is a form of brain exercise. We want to preserve connections with family and friends. Our support network is very helpful. And things like relaxation and reducing stress, whether it's yoga or breathing and music, they help bring down our anxiety hormones, which help to prevent damage for the brain. And you're already familiar with controlling vascular risk factors, which are important for the health of your blood vessels, which are, turns out, is important for the health of your brain. And getting involved in research is actually the last pillar of this, because we can not only access biomarkers, but we will move the field forward closer and closer to finding more and more treatments. We've been doing this now for 20 years. We've had lots of studies that failed, but now we're getting to the point where studies and drugs are starting to show benefit and getting approved. What are the non-pharmacological treatments? Simplifying medication regimes as we get older, that's important. Managing anxiety and depression. It turns out that a combination of aerobic exercise and mental activity may benefit MCI patients, especially with executive function. Many of the things that I listed already, they're important over the course of your lifetime to build up your cognitive reserve, to lessen the likelihood of developing symptoms, or lessen or delay the development of symptoms. The challenge is, once you're in the dementia stage or even the late MCI, many of these strategies, although important, are less beneficial than done early. Family counseling, education, connecting with support groups through the Alzheimer's Society First Link program, that's beneficial. Looking at safety like driving, or safety at work, or safety at home, and addressing hearing and vision loss we talked about as non-pharmacological strategies. What are the symptomatic treatments? We have had these medicines for now about 20 years, but currently in Canada, there are no approved treatments for the mild cognitive impairment stage of the disease, whether that's the current treatments that we've had for years and years, and we don't have these new treatments that we're hoping for in the near future. At this point, cholinesterase inhibitors have been the mainstay of treatment. They are indicated from anywhere from mild to severe dementia stage of the disease. So once they get to that stage, that's the time to start thinking of prescribing. Although the original studies looking at cognitive enhancers like cholinesterase inhibitors in mild cognitive impairment were not as, they didn't have the ability to look at biomarkers. So MCI patients of all comers were in that. So it muted the potential benefit that cholinesterase inhibitors might actually have in the MCI group, who we know have actual Alzheimer's disease. Glutamate modulators like memantine are indicated for moderate to severe dementia, and they are modest in their symptomatic benefit. And on this graph on the right-hand side, you can see that what it's showing is the bottom line, the horizontal line is the natural history, or the declining line is the natural history of Alzheimer's disease. The line just above that is where we've added a symptomatic treatment. And what you can see is we're trying to boost brain function, but it does not alter the course of the disease. It does not slow it down. So if patients come back to you and say, oh, this medicine seemed to help at first, but now I think it's not doing anything. In fact, it may well and most likely be still doing something, but because the disease progresses, the effect that they appreciate is lost, even though it's still positive. The dotted line would be when we do clinical trials looking for new symptomatic treatments, we're going to try and boost that benefit even more. So how would we follow up these MCI patients? So serial assessment is necessary, because between 10 to 20% of these MCI sufferers will recover. There's about a 5 to 15% progression of MCI to dementia per year. So over the course of 4 to 5 years, many of them will progress to the dementia stage. And this entails doing things like screening questionnaires with your annual assessments, where you're trying to pick up individuals who might have symptoms early on. Referral for clinical trials, we strongly support because of the nature of what we do, and it's the only way we're going to get to new treatments. However, we believe that these disease-modifying treatments are coming. They are now approved in the United States. Many Leqembi is approved since 2023. Donanemab is approved since 2024. Early diagnosis is required, and it's important because the earlier these drugs are started, the greater potential impact they have. We're waiting on Health Canada. hopefully this month and into the beginning of next year for their decision as to whether these are going to be available. They are currently available in Israel, in the UAE, they have recently been approved in the UK. So we are hoping they are coming shortly. What are these disease-modifying treatments? What do they do? So if, again, you look at the same graph that I showed you a minute ago for symptomatic treatments, the natural history is that black lower line. The dotted blue line is what disease modification does. It changes the course of the disease. It slows it down. And that's really important, especially early on. Why? Well, we talked about these are anti-amyloid antibodies. And what they do is they clear amyloid from the brain and can render someone's PET scan negative. So at the beginning of a study, let's say their PET scan was positive for eligibility. At the end of the study, their PET scan is negative. These medications work in slightly different manners depending on what aspect of the amyloid protein, whether it's the soluble amyloid or the plaque-bound amyloid, but they slow cognitive and functional decline, and they delay progression to the next stage of the disease. And as I mentioned, the FDA has approved this, and we're waiting on Health Canada. There are many clinical trials taking place in Alzheimer's disease. We will need more than just lecanemab and donanemab. We will need a cluster of treatments working in different ways addressing this. Much research is taking place in inflammatory related processes in Alzheimer's disease. This graph is put out this pie chart is put out every year. It's the Alzheimer's drug development pipeline. And what you can see is the perimeter of phase 1, the next ring is phase 2, and the third is phase 3. And drugs migrate along that course towards the center as they show potential benefits. So there is a lot of work going on in multiple mechanism of action. So participating in clinical trial, if you're not going to be eligible for one of the current disease-modifying treatments, is still very important. And what you can see here is these are the various approaches, whether it's a tau-based therapy, whether it's oxidative stress reducers or treatment for the vascular contribution, mitochondrial damage or mitochondrial targeting. There's a number of approaches. We're going to need a cocktail of drugs, basically. So we'd like to strongly support recommending partnering with us to find new treatments. So if you have patients who you've identified at different stages of this disease, we have many trials going on at the moment that have the potential for benefit. And so you can reach out to Justine Rehum, who's the manager of our clinical trial recruitment, email us, or patients can email us directly. Although there's a physician referral for direct to trials that we have on our website, patients can self-refer, or they can call our research number to learn more about how they can contribute and potentially become a medical hero in this field. And for us, every trial participant who's in studies actually gets a biomarker test. So much of what I've been talking about has been going on here for years. So thank you very much for listening. I realize it's a lot of content in a short period of time. I'm going to stop sharing and see if there's any questions that anybody might have, either by raising their hand or asking in the Q&A or in the chat.
We did have someone ask in the chat if the slides will be available.
We can make them available, sure.
Thank you.
Well, I guess we've answered all the questions, or we provided all the answers, or now people have an understanding, at least enough to move forward when they're thinking about this disease. You know, I often think about change behavior, much like you do in your practice. How are you going to get someone to actually implement a change that you've recommended? And that's difficult. So think about your practice. Think about when you're seeing these patients, and think about any hurdles that you might be experiencing in terms of the diagnosis and those various steps that I talked about. And you can reach out to us because we might be able to offer some recommendations or solutions that would be helpful. I see a question here. How often will PET scans need to be run on the same patient when starting a DMT? So at the moment, we're still waiting for, in Canada, the use criteria for these DMTs. So a PET scan or any biomarker that is clinically approved, PET scan or CSF, would be required in order to access the new DMTs at the moment. In the future, in a year or so, when blood-based biomarkers, plasma biomarkers, have been approved for clinical use, PET scans and CSF may be used in cases where the CSF, where the plasma test is inconclusive. So we will be using it more selectively. So plasma test is positive, we move forward. Plasma test is clearly negative, we move in another direction. Inconclusive, we may rely on CSF or a PET scan at that time. So that's how we use it. There's a question, MCI from hypotension and CAD. I'm not quite sure I understand. Hypotension is a sign potentially of autonomic dysfunction, which is seen in a very specific neurodegenerative condition, and sometimes a clue to that condition. It's an autonomic dysfunction. Hypotension and CAD. I think maybe there's some discussion about recurrent prolonged hypotension affecting perfusion to the brain. So I think in this case, that's one of those ones where if the by percentage of Alzheimer's disease is the most common presentation or one of the most common presentations of MCI or a leading, hypotension and CAD would potentially be a disease of exclusion. Let's see, does Toronto accept patients from outside the GTA? Can patients self-refer? So patients can self-refer for clinical trials. We offer free memory testing for people in the public because we know there's a challenge with accessing cognitive testing. So that is one of the routes. In terms of accepting patients from outside the GTA for our research program, absolutely. We have actually people who come from Vancouver for their research visits, or from New Brunswick, or from Northern Ontario. So for the research program, there's no geographical catchment. As far as the memory clinic outside the GTA, we do accept patients from outside the GTA area. With recent advancements in biomarkers for early diagnosis of Alzheimer's disease, such as plasma-based assays and neuroimaging techniques, how is Canada preparing to ensure equitable access to these tools across diverse populations, especially in understanding or in underserviced and rural areas? Very good question. I can tell you that there's more to the question, but I'll answer that part. So very good question. At the moment, Canada is not well prepared for rolling out treatment to large swaths of the population. But I can tell you that there is a lot of work going on amongst the specialists who practice in this area, looking at including radiologists, including anesthesiologists, neurologists, geriatricians, companies that have memory testing availability. How can we improve access to rapid assessment, let's say? So potentially having rapid assessment clinics that triage individuals who look to be in the earliest stage of the disease, who might be eligible. What we don't want to do is have people who have been identified as early in the disease to languish on waiting lists to the point where it takes so long that they're past the stage where these DMTs are applicable. So there is a lot of work going on trying to streamline and provide support for this. PET scans are very limited in their availability and they're expensive. Spinal fluids are certainly more readily available than PET scans. And the blood test will be the most available, but then you have to get to a clinician. So there's a lot of work going on in the background trying to prepare the Canadian landscape for this. Furthermore, what challenges do you foresee in integrating disease-modifying treatments into the healthcare system, considering the complexity of patient selection and monitoring. Um, the ability to monitor patients. So first we want to identify patients and be able to sit down and discuss with them the potential benefits and the risks of these disease modifying treatments. And that would be the same as in any other new treatment that might be available for all sorts of different conditions. So we want to be able to sit down and explain to them and to be able to identify what are the known risks, how do we keep them safe. So we've been involved in trials with these medicines, giving these medicines now for over 5 years. We are very familiar as a field amongst investigators with these ARIA, these amyloid-related imaging abnormalities such as microbleeds or microhemorrhages or edema. And there is, within the clinical trial, there's a protocol for how often we need to do MRIs to assess these. The good news is the majority of the side effects are asymptomatic, they are mild, and they resolve without intervention. There are guidelines that we use for when we can continue treatment with these disease modifying, and guidelines that say when we need to stop and wait till restarting it, or guidelines that say, no, we need to stop this. As far as the imaging monitoring that will need to take place, we are working with radiologists to develop a process so that perhaps the monitoring can be much shorter MRI sequences that will get patients into their MRI appointments and out without disrupting the system or making it difficult to have the MRIs. So there's a lot of work going on to look at not only how do we ramp up the assessment process, but also the monitoring and the safety process. So this is all going on in the background. For those with MCI in the single domain are at risk of AD, what is the percentage of risk? So I think I mentioned that, well, MCI is the etiological cause of MCI it's a broad spectrum of things. Alzheimer's disease is one of those. And what we know is that for people diagnosed with MCI, they have one domain of impairment, especially if it's memory, and we follow them. They will progress on, that cohort will progress on average from 5 to 15% per year to the dementia stage. So that's kind of the best that we are able to say, but it's certainly worrisome if somebody presents and clearly has objective evidence of short-term memory impairment, that they will progress. Also is related to what, for those with MCI in the single domain are at risk of AD, what is the percentage of risk? Well, the risk is over time that they will progress to the dementia stage, and also is related to what caused the MCI. Well, certainly knowing what the cause of the MCI will determine who progresses. So if we can do a biomarker test on them, if we have access to that, that's a huge advantage. So now we can say, look, you have the pathological evidence for Alzheimer's disease. Therefore, we can counsel on what is the expected prognosis, what are the average timelines. Everybody progresses at different rates, but on average. So we can have a conversation now that we know the pathological presentation. If we have a negative biomarker test that has a high specificity, good at identifying people who are truly negative, we can then say, well, it appears that Alzheimer's disease would be very unlikely. Let's look at other possible things. We can follow you, but the likelihood of you progressing is low because we have something now that we can use to rule in and rule out. Let's just see. I think there's one more comment. I realize it's after 1 o'clock. I appreciate all of you for sticking around to the end here. And we have a comment, an excellent and thorough presentation. Thank you. So I think that's a great way to end today's session. I really appreciate all of you joining. I hope you've learned something. You can share, tell all your colleagues, and we're moving forward into a new realm here very shortly with, we're fingers crossed with these disease-modifying therapies in Canada, which we need. We've been working hard for 20 years to find something to give to these patients, and they certainly deserve it, and their families deserve it. We need a lot more treatments, and research is the way we're going to get there. And once we get a treatment that works, then we have to roll it out. And yes, it's complicated and changes have to occur, but for sure our system is flexible enough. Look at all the other treatments that have come out for every other disease. Why shouldn't we be able to do this for Alzheimer's disease? So thank you for listening, and we'll all work together to get there. So thanks very much. Have a good rest of your day.